So welcome. I'm really pleased to introduce our speaker today, Deborah Schrag. Deb Schrag. I've known her since the mid-90s, so I'm really pleased that she was able to make the trip out here in the middle of winter. Deb is a GI medical oncologist. She's chief of the population sciences at the Dana-Farber Cancer Institute and is a professor in the Harvard Medical School. And is going to talk today about bridging efficacy and effectiveness knowledge translation in the progress in management of rectal cancer. Welcome, Deb.
Thank you. So I've had the privilege to do some work with Karen over the years. Rectal cancer may not be everybody's favorite topic, but I'm going to try to persuade you that it really is interesting and exciting and important. I know the University of Minnesota has a long tradition of colorectal cancer. One of my research mentors, who's now deceased, Doug Wong, trained here and was a leader here, and he spoke about this place often and with great fondness. So I think I know quite a few of you are basic scientists in the room, and this is the paradigm that is familiar to everyone, the traditional path steps between basic research to clinical research to better health for the populations. And we typically, often people think of this as a very linear process that goes step by step from the bench to the bedside to public health. But I think the world of big data and the world of clinical trials are changing, and it's becoming much more dynamic and much more fluid. And the focus of my talk today is going to be about how really we need to transcend these bridges and think across the divide here. And population scientists, clinical scientists, and basic scientists do well when we collaborate. So here's the traditional sort of translational knowledge translation steps. T1 research, early stage, phase 1 studies, moving things from the bench to the bedside, and really asking the question, can this treatment intervention work in humans? The T2 translation, really bringing things from the bedside for a couple of patients in very select small populations to, does this benefit a meaningful group of patients in a broad sense? So phase 2 and phase 3 clinical trials. And then there's T3 research, where can we actually build on this research and leverage it and actually deliver it reliably and consistently in the context of clinical practice? And finally, does it improve public health? And I've really been interested really in the T2, T3, T4 space in rectal cancer, and I want to try to give you an illustration this morning of some work in each. Usually, everyone starts on the left-hand side. I'm going to start with the public health on the right. So I'm going to briefly talk about, in the T4 space, how we think about, just give you an example. This is work that's in press about how policy decisions at the macro level influence colorectal cancer mortality. And at the T2, T3 level, how we conduct clinical trials that anticipate the challenges of integration into practice so that we do a better job anticipating and planning. And then finally, I'm going to focus on how we do a better job engaging patients in the translational research process. So these are U.S. colorectal cancer mortality rates. They're a couple of years old, but what you can see on the left is that colorectal cancer mortality, particularly in our over 65 population, has steadily gone down over the past decade and a half. In contrast, for the population under 65, rates, although much lower, are much, much flatter. As for many cancers, colorectal cancer also has a pernicious, persistent racial disparity such that patients who are not white continue to have higher mortality rate. So a few things about rectal cancer. Rectal cancer is about 30% of all colorectal cancer. The mean age is about 6 to 7 years younger than colon cancer, and it has a preponderance of men. It's about 25, 25, 25, 25. So about 50% of it is caught at the locally advanced stage when it can be cured, but requires a complicated regimen that includes chemotherapy, radiation, and surgery, and that's most of what I'm going to talk about. The very early stage disease can usually be cured with surgery alone, and the very advanced disease is incurable but can be treated with palliative chemotherapy. So it's well known, and I think those of you who are clinicians know that our patients who come into the clinic with rectal cancer, they're poor, they're more likely not to be white, and they're less likely to have engaged in regular primary or preventative health care. So the poverty gap in who gets rectal cancer is widening, and I think the reasons are obvious because of the rapid dissemination in the past 2 decades of colorectal cancer screening. So we wanted to ask the question about how much of the gap was due to people not having access to health insurance, particularly given the stable trends in the under 65 population. So we said parts of the country vary. State Medicaid programs are what insure people who are poor, and they vary. All state Medicaid programs cover colorectal cancer screening, but state Medicaid programs vary a lot in how generous they are and whether they cover adults at all. So we took a look state by state, and we bundle states into those who were generous before the enactment of the ACA, otherwise known as Obamacare. And here's what we saw. These are colorectal cancer mortality rates by year for the past decade, going back to 2000, for the United States. And you can see a slow downward trend. And again, this is only folks under 65, right? We're trying to explain what happened in the younger group. And if you look at states that are generous, that insure poor adults, you can see that generous states typically have low colorectal cancer mortality data. More recent data that's just become available, and again, these are state-by-state data, show that after Medicaid expansion, we see continued decline in colorectal cancer mortality rates that are consistent with their pre-ACA trends. What about states that expanded Medicaid? So these are states that were, if you will, not generous, but the ACA came along and said the key policy of the ACA has said you must provide health insurance coverage to all adults at 138% of the poverty line and below. So that's a big chunk of adults, right? So these are the places that expanded Medicaid. Here's the U.S. line again for reference, and here are the trends in those states. So you can see that they're higher. Their colorectal cancer mortality is higher than the U.S. average, but they've continued to come down. And when we look, we don't have all the state data in. It's coming in as we speak. But the trends show an accelerated rate of decline. So they're bending the curve. They're declining faster just from having expanded Medicaid, which went into effect in 2013. So you can probably tell what's coming next. What happened to the states that did not expand Medicaid, and how did that impact their populations? Here's the U.S. again for reference. There's Florida, a little bit worse. They didn't expand Medicaid. That's Georgia, significantly above. Virginia looks more like the U.S. Missouri, Texas. You can see that not only are these states, do they have worse colorectal cancer mortality to begin with, they're much flatter. We're not seeing the decline in colorectal cancer mortality. And the trends for the most recent data that is still emerging show that their trends are stable. So not expanding Medicaid is not good for your population's colorectal cancer mortality. So this is just an example of how you actually take policies and can actually evaluate and examine the impact on a disease overall. These are the 3 curves shown overall. And when you do the requisite statistical modeling and adjust for differences in populations using difference in difference models, we see a steeper decline in colorectal cancer mortality in early expansion states than in non-expansion states. So, of course, we can pinpoint things at a much more granular level than simply the state. We can employ hot spotting techniques. The areas shown in pink and purple are colorectal cancer hotspots. You can isolate this to the level of the county and the zip code, and you can see tremendous variation across the country. I think it's nice to see that both Minnesota and Massachusetts are nice. They're in the green. They're looking pretty good. Anybody know off the top of their heads what the most generous Medicaid programs are in the United States of all 50? Massachusetts is up there, but there's another one. Minnesota. So Massachusetts and Minnesota, they're basically the same. They slightly vary in some of the eligibility requirements because they're state. But Massachusetts and Minnesota do superbly well on healthcare quality indices and colorectal cancer mortality and other because of they have extremely generous Medicaid programs. So any cancer that's associated with poverty, cervical cancer, they look relatively better. You see the U.S. Southeastern Cancer Belt that pretty much shows up for all cancer, but there's some real hot spots in colorectal cancer. These are what the data look like for 2014. These come from the Institute for Health Metrics and Evaluation, a great resource that you might want to take a look at. These data are available, and you can manipulate them and manipulate the maps for any cancer that you're interested in. So much of cancer research is focused on efficacy. How do we develop better treatments and better interventions? And those studies are basically asking the question, how well can we make this intervention work? And this is the focus of most clinical trials. But effectiveness research is really focused on how do we deliver those interventions more effectively? And they ask the question, how well does this intervention work? And they typically involve pragmatic trials and large observational studies. And we look at the difference between efficacy and effectiveness, which we call the implementation gap, and try to use the implementation gap to understand why some areas on those maps are hotspotted. So this schematic shows the evolution of chemotherapy options for colorectal cancer. There's a lot of detail, but it all boils down to the fact that even though we've had a few new drugs shown at the bottom, the 6 shown at the bottom of the figure, to treat advanced disease since about 2000, we basically treat half of colorectal cancer, the kind that's locally advanced, with a combination of really 5-FU and oxaliplatin. We have an oral version of 5-FU called capecitabine, but basically we have very few drugs and they've changed very little over many years. This is a timeline that shows you the important phase 3 clinical trials in locally advanced rectal cancer. Just about all the progress that we've made in treating rectal cancer comes from large phase 3 cooperative group trials. First, the Swedish trial, the most important contributor, showed us that we need radiation because rectal cancer patients develop pelvic recurrences that cause immense suffering. Then in the 90s, we had the Dutch trial that showed that radiation improves local recurrence rates, even if a good quality operation, and a good quality operation in rectal cancer consists of something called a TME, which is a total mesorectal excision, which is an important surgical technique. For a long time, people tried to figure out if it was better to give the radiation and the chemotherapy before the surgery or after the surgery. And in the United States, we couldn't get our act together to ask that question. But the Germans were able to do it, and they figured out that preoperative chemotherapy and radiation were better than postoperative. And more recently, we've figured out that giving oral or intravenous chemotherapy amounts to the same thing, and then intensifying the regimen by piling more drugs on doesn't make any difference at all. But this is really the sum total of the major advances in knowledge over 2 decades. When you can fit it all in one slide, it's almost a little bit depressing. So what makes rectal cancer particularly challenging is shown in this trial, this slide, which is that it has a tendency to come back in the same spot, low down in the pelvis. If any of you have ever seen rectal cancer patients with the local recurrence, they're the ones who can't sit down. They feel like they're sitting on a tennis ball. They are truly miserable. They have trouble urinating. They have trouble moving their bowels, and they are in tremendous pain. It's why we give radiation for rectal cancer, and it's why rectal cancer treatment is so complicated. Before the era of radiation therapy, before it was used routinely, local recurrence rates were in the range of 25 to 40%, and those decreased to 7 to 15% with a consistent use of radiation. And for that reason, the use of pelvic radiation has been the standard of care in the United States since 1990. But around the world, there are many places, much of Africa, much of South America, there are no radiation oncologists, and high rates of pelvic recurrence remain a tremendous problem. These are the results of the Dutch trial, the total mesorectal excision, that compared high-quality surgery to high-quality surgery with preoperative radiation. And what you can see is that when you do a high-quality operation, the local recurrence rate at 10 years is pretty low, 11%. But it's even better when you add the radiation, 11% down to 5%. Treatment-related mortality is identical. Overall survival is identical. But patients pay a price for lowering that local recurrence rate. And the price is that many have lifelong fecal incontinence, with rates as high as 62% among disease-free survival. So we lower the local recurrence rate, but at a cost. And this is really an example where if you don't collect the data and you don't listen to the patients and you don't know what's happening, you don't really understand the consequences of the treatment. So this is the trial. This is a schematic for the German trial. They randomized patients to get their chemotherapy and radiation preoperatively or postoperatively. And here's what they found. The trial concluded that the preoperative strategy is better, and that's what we do in the United States. That's been the standard of care since 2004 in the U.S., and here's why. The local recurrence rate was better, 7% versus 10%. Distant recurrence, which correlates with survival, was the same. Survival was the same. And the rates of significant toxicity were a little bit better. So when people say, how do we get to where we are today in rectal cancer? How do we treat rectal cancer today in the United States? It's because of this trial that we typically manage people with, as shown in the blue box, 5-FU and radiation, then an operation, and then some postoperative chemotherapy. So we went from a situation in 2004 where almost 80% of people got their radiation after surgery to a situation in 2014 where nearly 70% get their radiation before surgery. This is a long and arduous treatment process. Radiation 6 weeks, there's a recovery, surgery takes a week, and then chemotherapy is 3 to 4 months. When we take a closer look at the German rectal trial, we see something interesting. The intention to treat analysis shown in panel A on the left shows a significant difference, 7% versus 10% in the preoperative patients. But when you divide it by how patients were actually treated and include the patients who had no postoperative treatment, the significance goes away. In other words, a lot of patients, even in the context of this clinical trial, did not get postoperative treatment. People get exhausted. They fall off the wagon. I can't do this anymore. They, for lack of a better term, they or their physicians quit. And this happens in clinical trials, but it happens in clinical practice even more frequently. And for this particular trial, it could change how you interpreted the result. So in the meantime, in the United States, we did a kind of a more boring study, but at least it gave us a very clean answer. We tried to give the 5-FU a few different ways, pill or IV. We tried to add oxaliplatin or not, but at least we got very clean results. Absolutely no difference. You can't see any difference between these survival curves. So the answer is you can give your 5-FU however you want, and since adding oxaliplatin makes no difference and it's toxic, don't add it. So these are the major rectal cancer advances in the last 2 decades, what we've learned. Doing a TME resection and radiation is better than just doing the TME resection alone. Giving preoperative radiation is better than postoperative. You can give 5FU however you want. You don't need to give the oxaliplatin. What I didn't mention is that doing a pelvic MRI helps predict who is going to benefit from a surgery. And we also know that giving a more intensified adjuvant therapy is better than 5FU alone. But all these trials leave us with a challenge. How do we integrate and sequence all these different strategies? We know in the real world that this complex care often doesn't happen and is often not delivered. So how do we try to look at it? Well, we try to gather data sets to say what is the quality of rectal cancer treatment outside the clinical trial context and how much does it vary from ideal practice? And what are the modifiable factors that account for this variation? And finally, is there anything that we can do about it? So to try to answer these questions, we use data from cancer registries, from well-characterized cohorts, from cancer centers that have collaborated, and from some NCI-funded cohort studies, including CANCORs. So this is just an example of what happens when you apply that lens to rectal cancer. So if you look in the clinical trial context from the German study, you see that all those patients had complete staging that includes a chest CT to rule out lung mets. If you go to expert centers, that only happens 94% of the time. But if you look out in community practice, generalized sample of the U.S. as a whole, those basic elements, something as basic as getting a chest CT, only happen 75% of the time. So we repeat this for different elements that are key components of high-quality rectal cancer care to try to understand the specific components of the implementation gap and how we can actually improve care. The other thing, of course, which goes without saying, is that patients treated in clinical trials and in the real world are different. Patients treated in the German trial are 61. 12% of them have T4 tumors. Patients treated even in expert centers are a little bit older, and in the real world, even older. And these are mean ages, so there are far more elderly patients who are consistently underrepresented in clinical trials. So we became concerned about a problem with the prevailing rectal cancer treatment paradigm that existed after 2004, after the publication of the German study. And that is that it took a really long time for patients to get any systemic therapy, about 4 months. And a lot of patients in the real world, outside the clinical trial, just fall off the wagon and never come back or never get their post-operative treatment. And that leads to potential undertreatment and missed opportunities for cure. Particularly, this makes no sense because what patients die of are not the local recurrences. Miserable as they are, they're dying from distant metastatic recurrences when rectal cancer spreads to the liver or the lungs. And distal recurrences outnumber local recurrences 4 to 5 to 1. They're more frequent and they're more lethal. So the other challenge, of course, is just as we have an undertreatment problem, we also have an overtreatment problem with the existing stage 2 and 3 rectal cancer paradigm. Local recurrences, the existing paradigm gives everyone 5FU and radiation and then surgery. And maybe not all those patients actually need the radiation. Maybe some of them have small tumors that could be resected well by surgeons without the preoperative surgery. And the reason we think this is that in the meantime, there's been lots of progress in colorectal cancer screening. So the tumors are smaller. They're smaller to begin with when they're found, and work by Karen and her group has shown that very nicely. There's also better imaging. Surgical technique has continued to improve, and chemotherapy itself has gotten better. So how do we balance this undertreatment, overtreatment problem? So I'm going to skip this. So we designed a pilot trial in the mid-2000s to try to address this. And we said, let's give the chemotherapy first. We know patients fall off the wagon. Let's give the chemotherapy first, and then let's see who responds. And if people respond well, we'll operate on them. We'll send them straight to surgery. This was done with radiation oncologists and surgeons all together. Doug Wong was one of the lead surgeons. And see if we can skip the radiation, because radiation's not that much fun, and it's long and arduous. If they don't respond to the chemotherapy, then we'll give them the radiation. So we followed this pathway. It was a small pilot trial. A lot of people thought it couldn't be done because we were taking away something, radiation, that had been shown to be effective. Took a while for the IRB to approve it. But this is the pathway that patients went down. 27 of 30 patients responded. 3 were either intolerant or didn't respond. And our 5-year local recurrence rate was 0%. Our pathologic complete response rate was 25%. And 27 out of 30 patients were able to avoid pelvic radiation. So this was a tiny single-center trial, but very provocative, right? So this is in the T2 space, but really suggested that maybe we could simplify rectal cancer treatment. So we then took this to the cooperative group, and we really didn't have a ton of preliminary data, but we persuaded our colleagues at other cancer centers to try to address this in a large phase 2 to 3 clinical trial. Could we use radiation selectively for locally advanced rectal cancer for patients who don't respond well to the neoadjuvant FOLFOX? So at the time this was presented in around 2010, it was extremely controversial to conduct a trial where you're actually taking something away rather than adding something. And lots of people were opposed, but eventually we were able to launch the Prospect trial, which is a cooperative group trial. It's currently open for across all the cooperative groups. And its objective, put quite simply, is can we give radiation to patients who really need it and skip it for those patients whose tumors respond well to FOLFOX? So again, we don't want patients to have local recurrence and suffering, but we also don't want patients to be getting extra therapy that they don't need. This is what the study schema looks like. The control group shown at the top are patients get the standard of care, 5-FU and radiation, then an operation, and postoperative chemotherapy. And the intervention arm looks pretty much like that pilot trial. People get 6 cycles of FOLFOX. If they respond, they go to surgery and get post-op chemo. If they don't, they get another opportunity to have the 5-FU and radiation. So we faced a lot of statistical challenges when designing this trial. We did it with Dan Sargent, who's actually a biostatistician in Minnesota, who he was a cancer survivor, and he's recently deceased from his complications of his childhood cancer treatment. But Dan was really helpful in thinking about effectiveness design strategies to make this trial feasible. Those included early stopping rules for local recurrences, a phase 2 into 3, efficient study design, and co-primary endpoints for both time to local recurrence and disease-free survival. So the upshot of the statistical design of the trial is that the selective or intervention chemoradiation arm will be favored if it either results in superior disease-free survival compared to the standard of care arm, or if it's non-inferior for both disease-free survival and time to local recurrence. So this trial really is at the T3 interface because it's a pragmatic trial. What makes it pragmatic? It has a lot of flexibility. It lets doctors treat rectal cancer the way they're most comfortable. That could be with intravenous 5-FU or oral 5-FU. Robotic or laparoscopic or open TME approaches are allowed. Postoperative chemo is at the discretion of the primary physician. We suggest 6 cycles of FOLFOX if no pre-op radiation, but it's not mandated, but we track and record exactly what's given. We encourage pelvic MRI, but some people are, particularly in the south of the United States, people can be too obese and heavy to fit in the MRI scanner. So if we made that an eligibility criteria, we selectively eliminate patients in those hot purple zone belts where obesity is so prevalent. So we also allow endorectal ultrasound. And we have quite flexible dose modifications and timing windows. So it's a phase 2 into 3 clinical trial. I don't have the final phase 3 results to share with you today, but I do have the phase 2 and some insights as to how we're doing. The phase 2 accrual goal was 366 patients with an early stopping rule, and no stopping criteria were met. The stopping rule said that after 11 total local recurrences, if the hazard for time to local recurrence was greater than 1.9, we would stop the trial, but that analysis is not yet mature. What that means is that we've had incredibly few local recurrence rates, which suggests that the intervention is probably working. Otherwise, the trial would have stopped. So we've had no danger signal, so we continue to accrue, and we've now, I think this week we accrued our 940th patient, and the study will be complete at 1,120. So we launched that trial with very puny preliminary data, but the Chinese came in and helped us out. They did something called the Fowler Trial, and the bottom arm here, the third arm of their trial, is similar to the intervention arm of Prospect. They are not powered for disease-free survival or time to local recurrence. They won't be able to look at it. But they did show that the R0 resection rates are similar. That right-hand full Fox column is essentially like Prospect. So essentially, their data suggests that it's safe, kind of the preliminary data that we didn't have. So more recently, many of you may have heard of the total neoadjuvant paradigm. The total neoadjuvant paradigm says, because so many patients after surgery don't come back and don't want any more treatment, let's try to give everything up front and save the surgery for last. So this is emerging as a really exciting strategy. I think it may be the wave of the future, but a couple of points. It may help address the undertreatment problem of people not getting everything they need, but it does not at all address the overtreatment problem. And we still don't have any phase 2s, or we have no phase 3s that evaluate this study. So when we designed Prospect, we really wanted to make it pragmatic and an effectiveness trial, and to really leverage what we can do with decentralized data and sharing data across sites. So we built in rapid central review of pelvic MRIs, because one of the challenges is that not everyone has an experienced MRI interpreter at their site. We have sites in Nova Scotia, sites in Alaska, sites in Montana, where the same person is reading the mammogram and the pelvic MRI. And we set up infrastructure where people upload the images and the central radiologist does a quick interpretation. And that's changed how people think of eligibility criteria and putting patients in trials and recruiting. And in a sense, the trial almost provides a quality check or care. And probably in the process of doing the trial, we've raised the bar on rectal cancer quality. This is a trial that's open at 250 sites. We also have a lot of tissue correlative studies, and rectal cancer is a great example for that. The tissue is super accessible. It's not morbid to do a rectal cancer biopsy. You don't need to be put to sleep, and you can biopsy patients. You get the surgical specimen, and you also get a preoperative specimen, so it's ideal for genomic correlative analyses. But we really wanted to know how patients would feel, what treatment strategy is optimal from the patient perspective. So we built in weekly monitoring where patients report their own toxicity burden. Some of you, I'm sure most of you who are oncologists have heard of the CTCAE, clinical criteria for adverse events. We developed something called the PRO CTCAE, where patients report their own symptoms. We also got frequent and regular quality of life. So Dr. Bash and I worked together to develop the PRO CTCAE. This was a large contract funded as a U01 through the NCI. And we systematically identified the 15 most common adverse events for rectal cancer. And we asked the participants in our clinical trial to report using their phones or their computers weekly from home how they felt during actually neoadjuvant and adjuvant treatment. So what's the model that what were we trying to change? This is the standard approach to symptom monitoring. Patient has to contact a hospital. They've got to overcome some hurdles, limited time, forgetting to discuss symptoms when they see their clinicians. This is the standard model, which is a really reactive approach. We all know patients bring their most important concerns to us. They don't like to complain. They don't want to skip their patients. This is traditional symptom monitoring. And what we were trying to do was to make the healthcare system less reactive and more proactive. So we sent patients e-reminders. We asked them to report their symptoms. If the symptoms were severe, we sent alerts to clinicians who could review the reports at visits. The idea being to bring patients and physicians closer together to monitor symptoms better, in the hopes that more patients would stay on their symptoms and we would see fewer patients, if you will, falling off the wagon. So this system, believe it or not, looks the same as the Citibank interface because it has the same bars as from when it was designed. That's what's usability testing. Older people, they could see this, they could read it, it was familiar to them. They could just press on these big wide buttons and report symptoms. This one just shows you what pain looks like. They then grade their symptoms, grade 1, grade 3. High grade alerts go to a clinician's in-basket. For those of you who use Epic, it's something like an Epic in-basket, and it shows up as flow sheets just the way lab flow sheets show up. So when we actually studied this, and this was actually a single center randomized trial of 800 patients done at Memorial, we had shown, this is not in Prospect, but we'd shown that when you randomize patients to standard of care or self-reporting, emergency room visits decline, and we actually showed in this study that patient survival, there was a survival advantage just from having patients report their own symptoms. And that's why we wanted to embed it in the Prospect trials. So we sent patients up to 2 reminders. If they didn't report, a central coordinator called the patients. 95% of patients were compliant by web and 91% using IVRS technology. 78% just did it spontaneously without reminders, and 15% needed those backup reminders. So here's what the results look like. The gray bars showed you how bad the toxicity was, what the clinicians said the toxicity was. The main toxicities of this rectal cancer treatment are neuropathy and diarrhea. What's shown here are arm A and arm B. It's still technically blinded, but those of you who treat this disease can probably figure out which arm is which. But this is what the clinicians have to say about toxicity. The blue bars on the right show what the patients have to say. So physicians collapse these constructs just into one, how bad's the neuropathy, how bad's the diarrhea. For patients to be psychometrically validated, you have to ask the question a little bit differently. For neuropathy, you have to ask how severe it is and how much it interferes with their usual activities. That's why you see 2 sets of bars. For diarrhea, the core question is the frequency. But what you can see is that the width of the blue bars and the amount of severe symptoms are much higher in the patients. So the clinicians are under-recognizing, if you will, or under-reporting toxicity. Just to show you that it's not just neuropathy and diarrhea, it's also nausea and vomiting. Same thing. Patients report more toxicity. The same is true for pain, for mucositis. So we consistently saw a different adverse event pattern between the arms of these trials. And we could see it with both the CTCAE and PRO-CTCAE. And the PRO-CTCAE was able to discriminate between the 2 arms of the trials. This is something that the FDA is looking at closely because when drugs get labeled, they want to know if they're tools that are able to distinguish reliably between side effect profiles for patients. And this trial was kind of a pioneer test balloon. There's no unapproved drug agents, but they could use it as a way to test the system. So inside the Prospect trial, we added one other feature, and I think this just shows you how you can kind of do population sciences or cancer care delivery studies inside cooperative group trials. We cluster randomized the sites to whether the physicians at the sites saw their patients' reports or they did not, because we wanted to understand whether doctors think that what their patients are saying about their toxicity is accurate or not, and whether doctors would change their scores. So half the sites have parallel reporting. Doctors report, patients report, but they don't see each other's responses. And half the sites have shared reporting, where the patients report, they come to their visits, the doctors can look, or the doctors can ignore. We ignore a lot of stuff at visits. We just blow through things quickly, and to see whether it made a difference. We did it with different case report forms. This was the parallel not shared. These are ugly forms, just like cooperative group forms are really kind of ugly. And the clinician just saw this and did the score. These are the shared, where physicians, when they scored toxicity, could see the patient's reports. Again, are clinicians influenced by patients' own reports? And we thought that they would modify, that they would be influenced. Here's what we found. This shows the pain shared and pain parallel, and the mucositis shared and the mucositis paralleled. You can see that the physicians in the randomized to the shared group sites had more symptoms. They recorded more symptoms when they were exposed to their patients' reports, suggesting that they actually trust the information that's provided by their patients. If you saw that, but you also saw more symptoms in the patients in the shared group, you'd say, oh, well, that's just because the patients in that group. But in fact, the patients in the shared and parallel had exactly, you can see those bars are exactly the same. So the patients had no difference. The randomization worked. But when physicians are exposed, they trust their patient's report. So it kind of suggests that we do believe our patients. And we saw the same thing all the way down. So clinicians trust patients' reports, and this is very doable. So this is a summary of toxicity by arm for neuropathy, and it shows you week by week, so you can get profiles over time. This is over the 6 weeks of chemoradiation. And this shows you that the symptoms in arm B of this trial are much more significant for neuropathy. This is clearly the FOLFOX-containing arm. This is the diarrhea, and it shows you that in arm A, the diarrhea is much worse, and in arm B, it's less. So again, if you're a person who wants to make a treatment decision based on symptom profiles, you can just have the patients report it and get the data, and it's very practical. So this system is now available through that UO1 research contract with the NCI. There's now a library of 89 symptoms. This same thing can be integrated and adapted into any clinical trial in any disease. It doesn't cover every symptom under the sun, but it covers most symptoms that are best reported from the patient perspective. So what are we trying to answer with Prospect overall? We're going to have lots of data coming out soon, I hope, but we are going to find out whether central imaging review and rapid cycle feedback can improve the quality of rectal cancer care at national scale. We're going to have data on the quality of TME rectal cancer surgery, because all the surgeons take pictures of the surgical specimens with their iPhones. We're going to answer the primary study question of whether we can simplify rectal cancer treatment and eliminate radiation. We'll understand the quality of life. We'll understand the molecular features. We have 931 patients so far. We need 189 more. And again, this is just really an example of a clinical trial that tries to think across the translational spectrum, anticipate the challenges of translating complex cancer care to day-to-day practice. So I'm going to, lots of people to thank. It's a collaborative team. And I'll stop there, take questions.
Any questions or comments, Scott?
Do you have any hypotheses about the characteristics of the tumor biology or the patient makeup that determines whether or not they would ultimately go on to require radiation?
So, lots of hypotheses, but we actually need the genomic data. So I think we're at 93% of patients have we get the tissue from the preoperative rectal biopsy, and then we have the TME specimen. And so we'll be able to look at what molecular features correlate with a complete pathologic response. We're running at about 20-25% of patients are having a complete pathologic response, and remarkably, that seems to be true in both arms. In other words, you can get a path CR with neoadjuvant chemoradiation, and you can get a path CR with systemic chemotherapy, and we'll look at all the standard genomic markers every day. The one that seems to be of most interest is it SMAD4 today, or they change. But we have a team of bioinformaticists who will be looking. It'll be quite a large data set, so we should be able to address that. We also have the MRI. We don't have MRI images in the control group for cost reasons, so we have baseline MRI on 100%. We have baseline MRI on about 85%. Some we have ERUSs and CTs, so we have MRIs on most people. We have a second MRI in the patients in the intervention group, but not the control group. So we'll be able to look at it.
David, go ahead, and then we have a question.
And just to say, there's the previous cooperative group rectal cancer trials have not collected biospecimens, so this will be the first one. R04, which I presented, did not.
So you showed a map allowing a hotspot analysis early in the seminar, and I think it was showing changes in the rate of death from rectal cancer, and many places were going down, but there were some places that seemed to show an increase in the rate of death from rectal cancer, these clusters in Appalachia. Do you have any explanation for these observations?
So I've actually been to Appalachia. I've been to Kentucky and West Virginia. It's not even all of West Virginia and all of Kentucky. It's specific counties, right? So it's multifactorial. It's complex. These are exceptionally poor areas. There's low colorectal cancer screening. But even when you take the screening off the map, what all those purple-pink hotspot areas have in common is that they are in oncology deserts, if you will. It is very hard to get to treatment. It's hard to get to radiation. They're not near the University of Minnesota. They're not near transportation hubs. So and when you actually look with the tumor registry, Kentucky's a SEER state, so we've been able to actually drill down on their data. You can drill down on it by county, and you can see that patients may get surgery, but they don't get the other components. So care that we've known is effective since 1990 is not being delivered. So we have a massive under-treatment problem there. Of course, there's also a problem on the diagnosis, early detection side as well. But even when you look at patients with stage 2 and 3 rectal cancer, they're not getting proper treatment. So it's not that we don't know how to treat them, they're just not getting it. So, poverty, maldistribution of healthcare resources in the United States, poor transportation.
Okay, do we have a question over at MCRB?
Hi, it's Ed Greeno. I have a question about the patient-reported outcomes issue. Mm-hmm. Can you tell how much that actually affected the amount of toxicity they were having as opposed to just what they reported? The point is, because you're getting toxicity reports more in real time, are we making interventions more often earlier than we would otherwise if we wait until they come into clinic? And is some of that difference not just the difference in reporting, but in fact because something happened that actually made the toxicity less?
Yeah, so in Prospect, 100% of the patients reported. Make sense? Like, we didn't randomize the patients to PRO, CTCAE or not. All the patients are doing it, so we won't really be able to tell how much. We don't have a control group with no toxicity reporting in Prospect. But from other studies, here's what I can tell you. Because this was an efficacy trial, this trial, the NCI said, let's see if it's even feasible to do this in a cooperative trial across multiple settings. Let's see if patients will even do it outside. Will patients even report outside the major cancer centers? So what we don't have, and what you want in answer to your question, is what are the actions that people took when they saw these reports? In other words, did people bring patients into the infusion room to get liters of saline and prevent them from getting dehydrated and prevent hospital admission? We don't have great data for that. But from other studies, we have data that that is happening. What was not done in Prospect was a systematic mandate to tell hospitals how they needed to use the data. Patients reported the data, but physicians didn't even necessarily look at it. So, Prospect's going to have very, very weak effects and impacts. It's sort of under-leveraging the potential power of PRO-CTCAE. The way we are doing it now is we take toxicity reports, and the mild stuff just goes into a flow sheet, like all those normal CBCs just go into a flow sheet. You can look at them, you can trend them, but we look at that for a nanosecond. But the significant adverse events go into something like an EPIC in-basket, where people can act, order a medication for a patient, and we're working particularly with EPIC, but also Cerner, to integrate the PRO-CTCAE functionality into the EHR so that it's minimally disruptive for clinical workflow, because none of us wants to be getting text messages or extra pings or reminders that are free-floating. That's just disruptive to how we deliver clinical care. So did I answer your question or not really?
More or less. So it sounds like from this study we won't be able to answer.
We won't because everyone's reporting. This study just basically shows that it's feasible for patients to report, and that what patients and clinicians report differ systematically. Patients report more toxicity. And I think we also know that clinicians change their toxicity reports. Clinicians believe their patients' reports. They don't think their patients are just exaggerating. They believe them, which I think is also pretty important.
Anything else, Ed?
No, that's all.
Any other questions
Question in the back.
from NCRB before?
Later. Sir. Okay.
Any other questions here in this room? Was there anything in Duluth, Nick, or any other location? No? Okay.
Thank you.
All right. Thank you very much.